we were discussing about hyponatremia clinical features. So acute hyponatremia, less than 48 hours, these are the clinical features. And then chronic hyponatremia, then the clinical features are less likely because of the cerebral adaptation. So that is chronic hyponatremia more than 48 hours. So evaluation of hyponatremic patient, it's basics again, history. We have to go into the details of head injury or brain surgery like in our scenario, and history of vomiting, diarrhea and burns, and history of diabetes. Those are the key components in the history. And it's important to review the drug chart. And in most of these sodium disorders, drugs can cause these problems. So administration of sodium bicarbonate or mannitol, then drugs which can cause nephrogenic DI like lithium carbonate, especially used in bipolar affective disorders. Then observation, which is very important. Most important observation will be urine color and volume and input-output chart. And also we have to inquire about NG suction, diarrhea. That means the water loss from extrarenal water loss. Then hydration status of the patient. And also important to check the random blood sugar and serum potassium and calcium, because hypokalemia can cause nephrogenic diabetes insipidus, and also hypercalcemia can cause nephrogenic diabetes insipidus. So majority of the patients, a diagnosis can be made on history and observation only, and only few patients need further investigations. So evaluation hyponatremia, further investigations, we usually go ahead with serum osmolality and urine osmolality. And unlike in hyponatremia, there's no catch. If serum sodium is high, always serum osmolality will be high. Then important investigation would be urine osmolality. So if it is less than 300, you can make the diagnosis of either cranial or nephrogenic DI. If it is in between 300 to 600, it can be either osmotic diuresis like in hyperglycemia or after mannitol, or it can be a diabetes insipidus also. If it is more than 600, that means patient is not losing water through the kidney. It has to be extrarenal water loss. It can be either diarrhea, vomiting, or some sort of extrarenal water loss. So these are the most important two investigations if you want to make a diagnosis, and also will be very helpful in the management. So management of hyponatremia. So this can be again divided into acute or chronic. So as I mentioned earlier, acute hyponatremia less than 48 hours. The goal is to lower sodium by 1 to 2 milligrams per hour and to restore a normal sodium in 24 hours. So here important thing would be acute one, we can reduce sodium say around up to normal levels within 24 hours. So to do that, we have to make sure that it's an acute problem. That means yesterday sodium was say 146 and today's sodium is 160. Then of course it's acute hyponatremia. Then important thing would be calculation of water deficit. That is total body water multiplied by current sodium value divided by 140 minus 1. So total body volume water, how do you calculate? So body weight is important, and plus important thing would be just to remember this easily, say 50-50, you can say 50-year-old man will have 50% of his body weight as water. So it means if body weight is 60 kilograms, then total body water content would be 30 kilograms, that is 30 liters. And difference would be when you grow older, say more than 60 years, then total body water content goes down. Say we can say 60-year-old man will have about 45%. Whereas if you are younger, that means less than 40 years, it will be about 55%. These are rough values. And compared to males, females will have lower total body water. So we will start with 50-45. So we can, it's easy to remember. That means 50-year-old female will have about 45% of total body weight as water. And you can reduce 5 say if the patient is younger, and if patient is older, and increase if the patient is younger. So it's just this formula. So then we can calculate the water deficit, and this has to be replaced over 24 hours in acute hyponatremia, and I will discuss chronic one. It is in about 48 hours. And you can use this formula, or it's easier to remember this regime also. And it has to be, what is the fluid we should give? It should not contain sodium. So you can give either IV 5% dextrose or NG water, or say if patient can take orally, oral water. So what is the infusion rate? You can give about 3 to 6 ml per kg per hour. And if patient develop hyperglycemia, then of course you can change to N/2. That is the only indication. But so you continue this infusion, and in about 12 hours time, you repeat sodium levels and to see the response and adjust the dose adjust the infusion rate according to the sodium values. And important thing would be, again, ongoing fluid losses should be replaced separately. And once sodium is normal, change to normal usual maintenance fluid regime. So fluid replacement in chronic hyponatremia, that is persist more than 48 hours. The difference from acute would be to lower the sodium by approximately 10. So in acute one, we can reduce more than that. But in chronic one, we have to be careful, mainly because now already brain cells adapted to this high sodium. So here you will give only slower infusion rates, 5% dextrose, infusion rate about 1.35 ml per hour into, that means patient's body weight. So roughly you can say, if the patient's weight is 100, then 135, but this is only replacement. That means deficit, but you have to give maintenance also, plus ongoing any losses should be replaced. So the maximum would be around 150 ml per hour. And as I mentioned, ongoing fluid losses should be replaced separately. So that is usually sufficient in majority of the patients. But if patient has diabetes insipidus, then we have to control urine output also, because otherwise what we are doing, we are giving IV fluids and patient is losing significant amount, sometimes even around 400 ml per hour, like through the kidney. So we have to have a mechanism to control urine output in patients with diabetes insipidus. This is only applicable for hyponatremic patients with diabetes insipidus. So if hyponatremia is due to vomiting or diarrhea, then there's no point of reducing urine output further. Already patient's urine output is low. So the drug would be desmopressin, which is a synthetic form of vasopressin, and it is also called DDAVP, D-amino vasopressin. That is the short version. And it comes in nasal puff, that is 10 microgram nasal puff. You can see the image. So it can be given to the nostrils, and it's available in oral form also, 100 microgram tablets, because that's important having these two routes, especially if the patient underwent transsphenoidal surgery. We can't use nostrils, mainly because already packed. So although not available in our setup, it's available as infusions or like injections, 1 microgram twice a day. And sometimes, although we are not using commonly, vasopressin also available. You can give it subcutaneous. For example, dose would be about 5 units 6 hourly. But the difference between desmopressin and vasopressin has vasoconstriction action. So if patient is having ischemic heart disease or peripheral vascular disease, if you give vasopressin, it will cause vasoconstriction, and it might worsen ischemic heart disease or peripheral vascular disease. So it's contraindicated, whereas desmopressin can be given. So going back to the clinical scenario, so what is the diagnosis? It's hyponatremia due to cranial diabetes insipidus. I have not given the urine output, but obviously there was polyuria. So management, two ways that we can manage. We have to combine both fluid replacement, as I mentioned earlier, plus desmopressin to control urine output. So if you do both, then sodium will come down. So that is about hyponatremia. Then we'll move on to hyponatremia, which is little bit confusing when compared with hyponatremia. So I will discuss two case scenarios. 38 years old male was referred again from neurosurgical unit with a sodium of 118, and previous day sodium was 132. History again, EDH evacuation done following RTA post of day 3. On examination, patient is confused. So that is one scenario. Second scenario, 67 years old male was referred with a persistently low sodium in the range of 122 to 128. And it is for 4 days, 6 days duration, and currently on treatment for pneumonia, past medical history, type 2 diabetes and depression. On examination, patient is alert, no neurological signs or symptoms. So these are two clinical scenarios where how do you manage these two patients. So again, we will have some background knowledge. Hyponatremia, the definition, serum sodium concentration below 135. And it's a very commonly encountered condition in hospital settings. Although hyponatremia, it's not so common, hyponatremia is very, very common. And usually, again, as I mentioned earlier, usually caused by a failure to excrete water rather than a defect in sodium handling by the body. As in hyponatremia also, it's mainly a problem with water balance rather than sodium itself. So clinical features, again, pathogenesis, it's usually due to neurologic dysfunction induced by cerebral edema. The previous hyponatremia, it's brain cells dehydrated. Here, because of hyponatremia, brain cell edema. So it is now symptoms related to the severity, that means the sodium level and rapidity of the change in the sodium concentration. And any hyponatremia, it's associated with increased mortality. So symptoms, again, we will divide as in hyper, acute and chronic. Again, same definition, acute less than 48 hours and chronic more than 48 hours. So if usually you don't get any symptoms, so if sodium is more than 130 and 120 to 130, you can develop nausea, malaise, and less than 120, headache, lethargy, seizures, coma, and obtundation. So these are important. This is acute symptoms that's related to cerebral edema. So symptoms of chronic hyponatremia, again, as in hyponatremia, may be asymptomatic due to cerebral adaptation. If there are symptoms, it can be non-specific: fatigue, nausea, dizziness, gait disturbances, forgetfulness, confusion, lethargy, muscle cramps. So those can be there, and it, of course, you can see there are so many differential diagnoses for this. So any elderly patient coming with these symptoms, it's very important to exclude hyponatremia. And it's important that seizures and coma in chronic hyponatremia uncommon. I won't say it's not seen, but I say it's uncommon. So hyponatremia, we can divide into two major categories. That is iso or hypertonic hyponatremia. That means now in both conditions, there's hyponatremia will be there. The differentiation comes from if you monitor osmolality. Low sodium with normal or high serum osmolality, that is called isotonic or hypertonic hyponatremia. And more common one would be in our practice, hypotonic hyponatremia, that is low sodium with low serum osmolality. So in hyponatremia, we have, it's a definitive, we have to mandatory, it's mandatory to do serum and urine osmolalities also. So we will discuss about the uncommon form first, that is iso or hypertonic hyponatremia. What are the causes for this? That means patient's sodium is low, but if you can say if you measure serum osmolality, that's normal. So although patient has hyponatremia, if you think about the osmotically active particles in the blood, it's normal. So it is a common condition would be hyperglycemia. So you have to think about this. The correction would be you have to add 2 milliequivalents to the sodium for each 100 milligram rise in glucose concentration. So say if blood sugar is 500, say normal sugar is 100. So we have to add 8. So if patient sodium is 128, the actual one would be around 136. So that's not a real hyponatremia. And then the presence of exogenous solutes like mannitol, and of course, after IV immunoglobulins, that also contain osmotically active particles. So sodium will go down, but these are transient. And again, another one would be due to surgical irrigants, like after transurethral surgery. This is not so common these days, mainly because we are using normal saline. But of course, if we are using sorbitol or mannitol or some other osmotically active particle, this is possible. Then there's condition called pseudohyponatremia. Mainly, this is a lab error. With the current analysis, it's not so common, but these things also we should remember. Hyperlipidemia, that means if patient's cholesterol is more than 500, either total cholesterol or triglyceride, there's a possibility of low sodium. It's an analytical problem. Another one would be hyperproteinemia. That's like in multiple myeloma. If serum proteins are very high also, you can have artificially low sodium values. So although uncommon, we should remember about these causes also. So we come to most common one, hypotonic hyponatremia. As I mentioned earlier, low sodium with low serum osmolality. Here the most important important observation to manage would be the volume status. So that can be categorized into 3 categories. It can be hypovolemic, euvolemic, or hypovolemic. So that's why patient's examination is very important. So you can see the differential diagnosis in each case. So if it is hypervolemic, of course, we have to think about renal failure, liver failure, and heart failure. So how this occurs? If it is due to renal failure, there's defective water excretion. So patient will have excess water in the body. And cardiac failure and liver failure, in liver failure, there's vasodilatation. So because of vasodilatation, activation of ADH system and renin-angiotensin also. And heart failure also, because there's low cardiac output, again, activation of ADH system. So that is hypovolemic. So if the patient is edematous, the management will be completely, the diagnosis and the management will be different. If patient is euvolemic, then the causes would be either more common one would be SIADH, or in psychiatric patients, there's a possibility of primary polydipsia. That means they keep on water drinking. And then hypovolemic, that means patients dehydrated. So it can be gastrointestinal loss or hypoadrenalism or cerebral or renal salt wasting. So differentiation, it's you can have, you see the volume status. And the other important thing would be looking at urine color and urine volume. That's usually sufficient. But of course, if you want to make the diagnosis correctly, you can do urine spot sodium levels. So if it is hypovolemic, urine spot sodium is less than 20. And if it is euvolemic, as in SIADH, urine spot sodium will be more than 40. And hypovolemic, urine sodium less than 20, that is GI loss. Whereas if you are using sodium through the kidney, then urine sodium loss will be more than 40. So if you have the volume status and urine spot sodium, you can make most of the diagnosis. So this is the diagnostic criteria for SIADH. It's a condition with hypotonic hyponatremia. So decreased serum osmolality will be there. And urine osmolality should be more than 100. And as I mentioned earlier, patient should be euvolemic. And if you think about the urine sodium should be more than 40, but that's not really mandatory. And you should have normal thyroid and cortisol axis, and no recent use of diuretic. So these are the diagnostic criteria. But if you have, say, first three also, you can make the diagnosis. It means low serum osmolality with urine osmolality more than 100 with uremic status. That's SIDH. So there are so many causes for SIDH. So we first diagnose what is the cause for hyponatremia. Then what is the reason for SIDH? These are the 4 categories you can remember. Think about malignancy, think about lung lesions, think about central nervous system lesions, and drug chart. So those are the 4 categories we should remember if you want to make a diagnosis. What's the cause for SIDH? So lung cancers, especially small cell CA, and GI cancers and bladder cancers and thymic cancers can cause. Pulmonary, any pneumonia, abscess, tuberculosis, cystic fibrosis, these conditions. Central nervous system infection or trauma, head injury, and even another common one would be Guillain-Barré syndrome, because I have seen a very resistant SIADH in some patients with Guillain-Barré syndrome. And drugs, very important. Basically, it's antidepressants and antipsychotics. So you can see fluoxetine and that group of drugs, antipsychotics like risperidone, and anti-epileptics, and NSAID is also. So if you get any patient with hyponatremia, always review the drug chart, whether any culprits are there in the drug chart. Because sometimes it's easy to manage. You just have to stop these drugs. So hyponatremia, now it's how to diagnose, and then classification also there. That again, it's easy: acute and chronic, less than 28 hours, more than 48 hours. Then depending on the sodium level, you can say it's mild, moderate, and severe. Mild, it's 130 to 134. Moderate, 120 to 129. Severe, sodium less than 120. So this is important in understanding the management. So acute hyponatremia, again, it can be divided acute and chronic. So symptomatic due to increased intracranial pressure and sodium less than 130, then we have to act aggressively here. So management would be 100 milliliters bolus of hypotonic saline over 10 minutes. So it can be repeated twice if persistent symptoms. And the goal of the therapy is to rapidly increase the serum sodium by about 4 to 6 over a period of few hours. This is to prevent cerebral edema and brain herniation. And so if any cerebral pathology like head trauma or anything less than 130, then we have to treat with hypotonic saline. Say if sodium is less than 130 and patient is completely asymptomatic, then we can give a 50 ml bolus of hypotonic saline if necessary. Then other category would be mild hyponatremia more than 130. Then no need of any treatment. Hypotonic saline is not indicated because cerebral edema and brain herniation won't occur at this sodium level. So then chronic hyponatremia, you have to be very careful in the management as in chronic hypernatremia. Similar to acute, 130 to 134 hypotonic saline not indicated. But of course, I know Dr. Nilaksha might know sometimes in neurosurgical setup, we might consider giving hypotonic saline just to keep the brain dry to prevent cerebral edema. And moderate to severe, that means sodium less than 130 with severe symptoms or intracranial pathology. So then again, hypotonic saline bolus should be given. And moderate, that is again same category, 120 to 139 with mild or no symptoms, then hypotonic saline is not indicated. So it's important to see that the patient is having symptoms or not, or whether there's intracranial pathology or not. And severe hyponatremia, that is less than 120, then of course, now I am telling about this chronic hyponatremia, which is lasting more than 48 hours. In that situation, we can consider hypertonic saline infusion. The usual rate would be 15 to 30 ml per hour. Or you can give 1 ml per kg bolus every 6 hours also. That is another way of managing. So both are acceptable. But important thing would be maximum rise sodium per day should be less than 8. So that is the most important message in the management of chronic hyponatremia, because if you are too aggressive, then consequences will be very dangerous. So chronic hyponatremia or hyponatremia management, it's go slow, because our target is just to relieve symptoms and prevent brain herniation than anything else. So what are the other methods of management of hyponatremia apart from hypertonic saline? Fluid restriction is very important, and indications for fluid restriction is SIADH and any condition with hypervolemic hyponatremia like congestive cardiac failure, liver failure. And amount of fluid restriction, that is also important. There's no point telling it's 1.5 liters per day. Now, important thing would be it should be below the urine output of the previous day. So usually around 800 to 1,200 ml per day. So you have to know the previous day urine output, then you have to restrict below that. Otherwise, it will not be successful. And you can see the effectiveness of fluid restriction also, and it's predicted by the urine to serum cation ratio. This is very easy. You just need serum sodium and urine sodium and potassium values. So it's ureum sodium plus potassium divided by serum sodium. So if ratio is less than 0.5, that indicates success. If it is more than 1, it's failure. So basically you can see if the patient's sodium is say 130, and if urine sodium is more than 130, that means what? More than 1, and fluid restriction will not work in this situation. Just need same investigation, just need the calculation. But important thing would be you have to calculate simultaneously. There's no point now yesterday's sodium compared with today's urine spot sodium. That will not work. It has to be simultaneous. So when you are ordering, it's always order simultaneously. If you are doing serum, it has to be with the urine osmolality, serum and urine osmolality together with urine spot sodium. So all the doctors, you should know, it has to be, if you are getting any patient with hyponatremia, if you want to do investigation, do all these 3 together. Otherwise, and once you treat also, it will be difficult to interpret. So on admission, because that's a real problem for us, because after management, partial management, say hypertonic saline, only we get the patients, then it will be difficult for us to make a diagnosis. So if you can do this then and there, it will be easier. It's just same plain bottles and urine bottles. So other therapies, we all practice this. Oral salt. It can be used with fluid restriction in moderate chronic hyponatremia. So how much salt, say 1 gram salt equal to 35 ml of hypertonic saline. So only problem would be palatability. How do you give salt? So one practical way of giving this would be you take some amoxicillin or some antibiotic capsules and you remove amoxicillin molecules from capsule and you fill it up with salt and then ask the patient to drink. Then the patient will not have this salt taste. So it's an easier way of giving salt replacement. Otherwise, they have to take added salt diet, which is very difficult. So then in some patients, we can try loop diuretics. May be beneficial in patients with SIADH with a urine to serum cation ratio more than 1, as I mentioned earlier. So in these patients, if you can give loop diuretics, and that will create a atmosphere in the kidney like ADH resistance. And then correction of hypokalemia also important, because correction of hypokalemia, the potassium moves into the cells, and so with that sodium comes out of the cell. So it will be important to correct hypocalcemia also if patient has hyponatremia. Then important drug, now it's available in Sri Lanka, not in government sector, but in private sector. A tablet cost about 500 rupees. And this is called vasopressin receptor antagonist. And the action would be, it blocks V2 receptors in distal convoluted tubules and collecting ducts. So here the SIADH means there's inappropriate ADH secretion. So what you can do would be you block the ADH channels. So ADH acts through V2 receptors. So if you block V2 receptors, then ADH can't work on this. So that's a one way of treating SIADH. But you have to be careful in treating with these drugs. At the moment in Sri Lanka, tolvaptan available. It comes in 15 milligram tablets and oral tablet. Conivaptan not available. The indications: resistant or chronic SIADH, usually hypertonic saline, fluid restriction, and oral salt is sufficient in majority of the cases. But very rarely you get patients with chronic SIADH, like if the patient is having an ongoing cancer, then SIADH might be there. And also it is very effective in treating congestive cardiac failure with low sodium, because anyway, if you give if you block V2 receptors, then ADH action won't be there, so there will be diuresis. So it will improve heart failure and plus improve sodium, because it's a dilemma in the management hyponatremia with heart failure. However, important thing would be it's contraindicated in liver failure. So because there are some reports, it can't be used more than 30 days also because of the liver toxicity. So it should be short term, and you have to monitor liver function. So it can't be used in liver failure. So I have to mention about this one also, because it's osmotic demyelination syndrome. It is central pontine myelinolysis. It's a iatrogenic condition with rapid correction of hyponatremia. So this is due to now it can occur even with 8 millimole rise of sodium also, but usually occurs with more than 12, and especially in the setting of chronic hyponatremia. What is the pathogenesis? So now brain cells, what has happened with hyponatremia, there's cerebral edema. Then you correct too rapidly, then there's rapid fall in brain volume, result in demyelination, and which is best explained by the direct injury to astrocytes and oligodendrocytes. So there's initial cerebral edema, and then with hyponatremia or overcorrection, there's rapid shrinkage of the brain cells, and which cause demyelination. So clinical features, usually you won't see with correction itself. You have to wait till 2 to 6 days, and most dangerous thing would be it's irreversible. You can't reverse this. The symptoms will be dysarthria, dysphagia, paraparesis, quadriparesis, behavioral disturbances, and movement disorders like Parkinson's, seizures, and coma. And you can see this happens in now central pontine myelinolysis. That's through like pons. So it's a very important area of the brain where all these tracks goes through. It's the pons. So there will be bulbar signs, corticospinal signs. So diagnosis, it's by MRI brain. Sorry, I don't have a cursor, but you can see pons. There are some hyper intense area. So that is a feature. But sometimes at the initial MRI might be normal. So you might have to wait about 1 month to see whether it's actually osmotic demyelination syndrome. So management, as I mentioned earlier, it is irreversible. So prevention is the best method. But of course, sometimes there might be a place for rescue strategy. So you treat, but without your intention, there might be over treatment. So in that case, if sodium is more than 10 rise for 24 hours, what you have to do would be your management of hyponatremia. As I mentioned earlier, management of hyponatremia, it's desmopressin plus dextrose infusion. So say sodium is initially 112 and the next one will be 130. Then what you can do would be you artificially lower the sodium value, like what we did in diabetes insipidus. You give desmopressin to control urine output and dextrose infusion for hydration. So that can be done as a rescue strategy if you have really gone out of your comfort zone. So going back to clinical scenarios. So first one, 38 years old male referred from neurosurgical unit with a sodium of 118, previous day 132. So this is acute hyponatremia and history EDH evacuation done. So the diagnosis is, of course, you should have serum and urine osmolarities, but clinical diagnosis and biochemical ones. It's SIADH due to brain trauma leading to severe hyponatremia. So in this patient, definitely we have to give hypertonic saline plus follow up with fluid restriction and salt replacement. Second one, 67-year-old female referred with persistently low sodium for 6 days. So that means it's a chronic hyponatremia. Currently on treatment for pneumonia, past medical history, type 2 diabetes and depression, and non-neurological signs. And what's the diagnosis? Again, SIADH, but different cause. As I mentioned earlier, 4 broad categories: lung lesions, central nervous system lesions, drugs, malignancies. This one, it's SIADH due to pneumonia and or fluoxetine patient on depression treatment. So this lead into chronic hyponatremia. What is your management? Of course, withhold fluoxetine and fluid restriction and salt replacement. In this situation, hypertonic saline is not indicated. You might consider this if patient has severe hyponatremia less than 120 with symptoms, then you might consider hypertonic saline, but not in this patient. So just take home messages. Hyper or hyponatremia is commonly due to a defect in water balance rather than a pathology in sodium itself. Although name says hyponatremia, it's a problem with water. And volume status, urine output, and urine color are very helpful for diagnosis and management. And third message, aggressive correction of hyper or hyponatremia is associated with adverse outcome, especially in the setting of chronic hyper or hyponatremia. So thank you very much for patient listening.
Thank you very much, Mr. Kahandawa. It was a very nice, well-organized lecture, which gave very clear illustration about management of hyponatremia. And now the forum is open for questions. I think there have been a lot of questions to face lately. I'll ask one question. In decompensated cirrhosis, most of these patients are hyponatremic, but they are asymptomatic. So, what would be the management strategy?
Yes, that's a real dilemma, because now you have to give furosemide also, and so many other drugs also going on. So, and now cardiac failure, tolvaptan is a very good option, but we can't use in liver failure. So we don't have much options than fluid restriction. So, and of course, hypertonic saline can be given. And in hyponatremia, there's no point giving normal saline because it's similar to our normal blood. So options would be fluid restriction and hypertonic saline. And hypertonic saline, sometimes, as I mentioned, sometimes in some patients, now what we can do would be, now we can't block ADH response. Now it's due to vasodilator pathology. vasodilatation due to renal liver failure. And because of that, the carotid baroreceptors sense low pressure because of vasodilatation. Then ADH release will be there. So, but we can't block ADH release because it's contraindicated. So only we are left with fluid restriction and hypertonic saline. Yes.
All the diabetics, both prosimide and spironolactone, stick to it to around 1,000. Just monitor the electrolytes and most of the time patients with the sodium less than more than 100.
Yes. No, I don't have any experience on actually. It's only 3%. I don't think it's available in our setup. Yes, but most of these European guidelines also mention it's 3% one, and these boluses are also with 3% normal saline. What they are doing, and Europeans I think do 150 ml 2 doses. In between they check sodium, but this guideline says 100 ml 3 doses. But again, same volume. But I don't have experience on that.
Any place for glucocorticoid?
Yes, glucocorticoid I have not mentioned because of time. Its indication would be hyponatremia in say cerebral salt wasting or renal salt wasting. So I haven't mentioned cerebral salt wasting. That's in the category of hypovolemic hyponatremia. The major difference from SIDH would be these patients will have polyuria. So polyuria, that's now in that situation, yes, we can give fluticasone, and but we have to make the diagnosis. Otherwise, if we give in SIDH, that will be a problem. So in cerebral salt wasting, there's indication.
So, in the absence of questions, I would like to conclude this session. And again, I would like to thank Dr. Kahandawa for his presentation.